today we're talking about depression. And so we have some providers here who work with clients that come in with that presenting issue, and so we're going to learn a little bit from their expertise today. So first I wanted to go through and see if each one of you could introduce yourselves, talk a little bit about your work, and maybe work specifically with clients dealing with depression and what that has looked like. So Dr. Reinhardt, do you want to?
Sure, I'm Mark Reinhardt. I am the program director for the Family Nurse Practitioner program here at Texas A&M. I'm also an emergency nurse practitioner by training, so this kind of is right up my alley of patients that I see. I've been an ERNP for about 13 years, so I've seen quite a few cases of this type of around the country. Worked in ERs in the Army, and I'm retired Army, and in civilian hospitals. So this is a good, this happens almost on a daily basis for people like me.
Hi, I'm Jessica Hinojosa. I'm a case manager at Youth Services, MHID. I work in Yes Waiver, so that's the highest level of care that the kids can be in. So all of the kids that I currently work with have, the suicidal thoughts, like the case study, depression, all of that. And the kids are all diagnosed with at least one diagnosis, if not more. So depression, PTSD, those kinds of things. So.
Hi, my name is Dr. James Ikonomopoulos, and I'm a licensed professional counselor supervisor. I contract with Nueces Center for Mental Health at the Youth Service Program, and I also work with Jessica. And so we'll work together as a team. We'll be assigned clients that will come in, and I'll be providing cognitive behavioral therapy with them while I'll work with Jessica as we'll kind of talk and collaborate about the client's goals and move forward with treatment recommendations. But mainly cognitive behavioral therapy is what we're allowed to provide as a therapist. We can integrate other approaches, but CBT is mainly the treatment. That's what we're required to do.
I'm Dr. Groff. I'm a psychologist. I work at Driscoll, and then I have a small private practice. So at Driscoll, I see mostly kids with developmental problems or autism or medical issues. So I do mostly evaluations, but with the kids with medical problems, if they're depressed, they come to me too. And then in my private practice, I see a lot of suicidal patients.
Thank you all for being here today. So if we look at the case study, you'll see we have Andrew, who is a 16-year-old African-American teenager. He has gone to the emergency room, or his mother has taken him to the emergency room because he is having suicidal ideations. He has expressed that he feels like killing himself. She has noticed that in the last few months that he has lost interest in life, has been feeling down. There's been some weight loss, difficulty sleeping, and then also a diminished energy and concentration and ability to do his schoolwork. So seeing some effects at home as well as at school. His grades have dropped overall. He didn't make the football team, has lost some friends through that, as well as there's been some more distance with his father. And so all of these issues have kind of come together, and it has come to the point where the mother is concerned about him to bring him to the emergency room. So that's kind of the big picture of what we're looking at in this case study. And so the providers that we have that are going to be working with Andrew, we have kind of the emergency room, medical professionals. We have a case manager, LPC, as well as a psychologist. So Dr. Reinhardt, I wanted to start with you because that's really where Andrew kind of enters into care, is through going to the emergency room. And so as Andrew comes into the emergency room with his mother, I'm curious, what are the things that you would be looking for, and kind of how would you approach this case starting out?
Well, I think that, unfortunately, a lot of adults and kids end up in the ER with depression or suicidal thoughts. And so we're kind of the gateway, if you will, to, just like in primary care, people don't have access to primary care, they may not have access to mental health services, or really even know what's out there. groups like these professionals next to me that they're able to know that. So they come in to the ER, and these patients are very, very tricky. I've lost more sleep over patients with suicidal and depression behaviors and ideations, because you never know once we release them, if we release them to go home on a plan or whatever, there's still a risk. And if we don't make sure, and in the ER, it's very difficult because we don't have the ability to follow up with patients that we might want, or sometimes there's a fear of they say what we think we want to hear so they can go home. Kids are, I think, are extremely difficult, and I don't mean that in a bad way, because they have so many pressures and they have so many things these days that they're putting pressure on them, such as social media and bullying. And so I was reading a study that said that this time in our country, the adolescents are at the highest stress than they've ever been. And so the risk for suicide and those type of things are very, very high. So when a patient like this comes in with their mother, first thing I like to do is I like to go in and introduce myself to both the mother and the patient, but let them know my role, let them know what I'm here for, let them know what's been told to me, but let them know very quickly that I'm not making any judgments to them or about them. I'm not there to judge them. I'm not there to do anything. I'm there to help them in their time of stress and need. And it really, I think, kind of opens it up to where they feel a little more comfortable. Because usually the kids are, if you will, pissed off because, one, the mom's brought them in there, they don't want to be there, they're embarrassed that they're in the ER, and then the thought of, I'm here because you think I want to kill myself. I've had many kids say, well, I didn't have that, but now that you brought me here, now I do want to kill myself. And then that's a fear as well, and are they lashing out in that type of behavior as well. So first thing I do is I like to get kind of a background a little bit from the mother about why she brought her son to the ER. And usually I like to have some of those conversations without the child present, just because it's very distressful to him or them to hear what is being said about them. But I let them know up front that because anything that the parent says to me, again, I'm not making a judgment on them. So it hopefully it makes them feel a little more relaxed, because they're heightened, they're psychomotor, and they're going to be heightened and agitated because they're there. And then once I talk to the mother and kind of get the background in the first, I guess, 2 paragraphs of the case study, then I go in and I tell the mother that I want to talk to the child alone. He's old enough that we can have a conversation. I find it beneficial with children to be a little more open about who I am than I might with an adult, and give them a little more information about me, because I think that helps them understand that the relationship that I'm trying to set up with them is one of true compassion, wanting to learn about who they are and wanting to help them the best way that I can. So getting a history, but I see that in my I guess conversation with him, he is agitated, and he's breaking through that yes and no, and a lot of times that's really what you get with kids. It's that yes, no. So it's hard to kind of get through that, and especially because he's agitated. So kind of breaking through that is going to be rough. What I do first of them, I sort of open the door and have a conversation, but I also do a very thorough physical exam on them as well, to make sure that I don't think that they're having some sort of acute with some sort of metabolic issue that's going on, diabetes or something, or new onset of some sort of disease process that's going on. So I have to clear them medically even before I might contact somebody else to come in. And then I have a kind of a brief conversation and get their history and get all of those things. So that's how I open the door of the conversation with them. But it is with a very thorough exam as well. And also with some lab work if necessary too, to find out if they're not. Again, we know that their patients aren't always honest with us. So we need to know if there's alcohol or drugs or something involved. And we need to know what their lab work says to see if they've got some underlying metabolic condition. And you know, this young man has played football. Maybe there's a TBI issue involved in it or something as well that we need to make sure that something is not medically deficient or a problem before we even include an outreach for them.
And so after that assessment, if you do, as you identify if there are other providers that you believe would be helpful or need to get involved, what does that process look like from the emergency room and kind of referring out to other?
Well, what we typically do is that we call who was ever on call for it'd be for adolescents at this point, and see if they're available to come do an assessment on the patient, because like I said earlier, it's very not only from an emotional standpoint, but also from a medical legal standpoint for me to make a decision to send a patient home, even though they may be adamant. I'm not suicidal. I'm not going to hurt myself. This is all a joke. My mom overreacts. I want to go home and play video games and see my dog, and I'm not going to do anything to hurt myself. And they get very adamant, very agitated. So that's when I reach out to the smart people to come in and do an assessment, even if it's by phone, to do an assessment of a patient, or if we need to refer them, because the problem in this area, we don't have, now we do for a 17-year-old, or I'm sorry, 16-year-old, but you know, if you have patients that are under 12, we really just don't have a whole lot of inpatient services, but not every kid needs to be admitted. If we can set up some sort of a plan, but I as a medical provider have to rely very heavily on their expertise and whether they feel like that the child could go home with the mother in a safe environment.
So we'll say youth services gets involved at this point. What would be the entry point kind of with youth services and what you provide? Where would they start with?
So once a kid comes in to services, and if they've been in the ER and say that they were referred because they didn't get hospitalized, and so they're just coming to us for outpatient services, then we would do a screening, and whoever is on call that day would do the screening. And it's not very thorough, but they just ask like basic information about the child, what brought them in, who referred them, those kinds of things, what's going on either at school or at home. Once the screening is completed, we give them an intake, and they come back to meet with a counselor. They do an assessment with the counselor, and that's usually like a 3-hour long appointment, and then they get more background information about their family, family history, any type of like drug use, alcohol use with the kid and the family members. Once the intake is completed, then they get set up either with a psychiatrist in-house. So we have psychiatrists that are there and see the kids, 3 of them, and then they get set up with a counselor if they meet that level of care. So for Andrew, who has like these suicidal thoughts and who has been possibly in the hospital before, I don't know, he probably would come out to a level 3, which is the highest, like I said, and 4. And the child and the family can choose to stay at that level, or they can choose to go lower and not really get the services that we recommend, but they want to do maybe like just skills training with the case manager, or they can do skills training and counseling depending on their level of care.
And so would some of that be due to maybe the assessments that are done that would determine what the
Yes,
level would
yeah,
be? Okay.
yeah, so.
So I'm curious, Dr. Graff, from your perspective with assessment, what would be kind of the assessments that you would want to bring in, and kind of what would that piece look like for you with Andrew?
Well, I mean, if I see the depressed kids, and that have some suicidal history, it's always the question of how much containment do they need? Can I do it on my own? Do I have to send this person somewhere else, to somebody you see them more often? So then that depends on other factors like what's not on here. How often does the suicidal thoughts happen? How can they talk about them? Are you able to engage them in talking and seeing them on your side? Do I have the personal resources? How many depressed people do you have on your schedule? Can you still handle another one because it's pretty draining? What are my own resources at the time in terms of time? I have to see this person at least once, maybe twice a week. So if I can't do that, I need to send him somewhere else. So there's kind of especially in the first meetings, a lot of practical things to think about. What's the next step? Or the medical issues, like hypothyroidism can look like depression, just identical. So all this could be the same, you just have hypothyroidism, but you wouldn't know. So that's a medical referral. Then, does this kid have a personality disorder? Lots of kids have personality traits or disorders, so impulsive behaviors, risk-taking, drug use, promiscuity, and then depression on top of that. But the depression is just like the tip of the iceberg. So you have all this other stuff, or a family that does not really do enough, or doesn't set limits. So a teenager in that environment where the parents feel sorry for them, they give more than they should, they don't set the limits. So that's more kind of like, does this kid have a personality disorder? Or sometimes they might be sent to me for that reason. The kid is on depression medication, goes to treatment, but is not getting better. So then the other kids I see are kids with medical problems, like kidney transplants, diabetes. I'm diabetic, so I know a lot about that. That's just like, I don't want to live anymore. It's just easier to stop taking care of myself. So then you have this implicit suicidal behavior that's not really, just by not doing anything for yourself, you're killing yourself. And so that's kind of harder to work with, but it's a reality too. So, but one of the pitch I wanted to make is like, every mental health provider should have a niche, like something where you get training, supervised training, certification in, so you can tell other people, this is what I do. So I work with depressed kids that get suicidal in an outpatient basis. Whether you have DBT training, where you are hooked up with other people, have a group of people where you have family and individual treatments kind of as part of, and a group of people you work with. Because like at Driscoll, we had a program where everybody got screened. The American Society of Pediatrics, 2 years when they realized there's all these suicidal teenagers, they came up with a recommendation that all the kids should be screened with this PHQ-9. So all the, in the pediatric practices, they do it. Then we started Driscoll, but then like, hey, half of them are suicidal, or maybe a quarter of them, and they just didn't have the resources. Suddenly, you open this can of worms, and then they had to close it again. So for now, there's no screening for suicidal ideation at Driscoll, because people were, physicians couldn't go home, or when they went home, they had nightmares. So now they have to develop kind of a better system. And in our community, like, so in my private practice, I see kids that they're released from the hospital, and they really don't have a place to go, and well, so then so I think working with suicidal kids, you need a certain comfort level with talking about suicide and having suicidal thoughts and learning how to live with them. They're not gonna go away, they're gonna be with you. Some people have them all their lives. So for some people that's a reality, and you want to share that reality with them and how to work with that, as opposed to not wanting to go there, which is what most of them are faced with most of the time. Like, nobody really wants to talk about suicide, so they don't talk about it. But, you know, the ones who do talk about it are much more likely to not do it, you know, so that's the better part of it, you know. And the one thing that's not in here is he didn't break up with his girlfriend, kind of thing. Because that's 50% of the kids who actually could kill themselves is after a breakup, you know, that's the most likely thing.
You know, I think another thing to add to that too is now with, that's a great point, is that nowadays we see so many kids that struggle with their own sexuality. We really see that, and if he's questioning his own sexuality, I think that's could be a huge piece that I ask in my intake with the patients, and I'm very non-judgmental, but I ask because we see that with a lot of kids coming out as transgender and those type things, is that we have to be sensitive to that, because that can cause those issues as
There's
well.
a big risk for suicide.
Huge risk,
Yeah.
and I think so. All of those questions need to be asked. That's a great point.
So as Andrew would get into care with youth services, tell me kind of what that ongoing care would look like.
I want to say a little bit more too about intake. So when they come in and they get screened, and then we'll determine whether or not they're eligible for an intake. Oftentimes we'll do an intake that day that they come in for a screening, because we try to limit the amount of time that somebody goes without any care at all. So if a counselor is available for an intake, then they'll do the intake. And so an intake is a long session. It's about 3 hours, like Jessica said, and we'll administer a few assessments. So one is a biopsychosocial assessment. We'll gather information about personal history, psychological history. We'll also administer what we have as a uniform assessment throughout our agency, which is the CANS assessment. It's the Child and Adolescent Needs and Strengths Assessment, and that asks a lot of questions regarding needs, psychological problems, social problems, as well as strengths that the client has, and as well as strengths about the family and the guardian. And then from there, we'll also ask about suicide, and anyone who comes in who's had a history of maybe suicidality, especially if they're coming out of the hospital, they have to be seen within 7 days, actually, from coming out of a hospital. So the sooner that they come into our outpatient community agency, the better. So Nueces Center for Mental Health is an outpatient community agency where they'll be released from the hospital, they'll live with the parent, right, or with the guardian, but then they'll come in for services at our office, and then we can see them at school or out in the community. But when they come in for that intake, we'll assess for suicide, and I'll have to administer what's called a suicide risk assessment. So I'll ask questions like, are you having any thoughts to die? And they may not have suicidal thoughts, but they might have thoughts about dying. So that's an important thing to kind of know. And then I'll ask them next, are you having thoughts to kill yourself? And I'll ask that specifically. And like Dr. Graff was saying, many times clients are not wanting to really open up and talk about that. But when you're asked that question, maybe they'll be more open to talk about that. So it's important that you do ask that question. And remember, there's no problem asking that directly. You're not going to encourage them to have more thoughts, okay? So just don't be scared to ask that question. Are you having thoughts to die, or are you having thoughts to kill yourself? Then I'll ask them if they have a method to kill themselves. I'll ask them if they have a plan. I'll ask them if they have a means. And then I'll ask them if any time in their history have they ever attempted before. So it's important to know their history too, because then you want to create what's called a safety plan. And so a safety plan, many of you have maybe heard about safety contracts where somebody agrees to commit to safety, but I find that safety plans are a little bit more helpful because you actually plan something that they can do to stay safe and redirect their thinking. So of course you can't just solely depend on a safety plan, and assessment is ongoing all the time when it comes to suicide. Like every session that I'll have with a client, I have to assess for suicide. I have to administer that suicide risk assessment every session with the client that has major depressive disorder. So that's really, really important. And then we'll review the safety plan that was created at intake, and sometimes new safety plans are created. And so what's a safety plan? So a safety plan is where you identify steps to make the environment safe. You'll identify like warning signs, the triggers that cause them to have suicidal ideation, and then you'll explore like internal coping strategies, things that they can do to remain safe, external coping strategies, things that like other people can do or places they can go, and then you kind of like all add all that up together and you create a safety plan and you inform the family about the safety plan. And sometimes they'll not keep track of their safety plan. They won't really take the steps that you've discussed to stay safe. So it's really important that we constantly monitor that. I mean, if a client's in crisis, they could be in a crisis again. They might come in for that intake. You ask them, are you having suicidal thoughts? And they are having suicidal thoughts. So that's when you're not doing therapy anymore. You're doing assessment for safety, and you want to make sure that they can commit to safety. And then once they can commit to safety, and you feel like the family's on board and that the client's able to remain safe, then you don't have to recommend hospitalization, but it's always good for them to go to the hospital. We don't ever admit people to the hospital. The hospital does that. So the hospital will determine whether or not someone's eligible for admission. But after that, then you'll have your initial counseling session, and I'll base the goals like this. Based off of the needs that they come into counseling with, like from what the CANS assessment says, that helps me kind of know what goals to work on with them, but the goals have to also be collaborative. That means that they have to have a say in the goals that they want to work on. So many times, case managers are the ones who will start the treatment plan, and then counselors will then go on and add goals that the counselor and the client have worked on together. But the client may say something like, I want to just have more friends. Like Andrew, from his case study, he has thoughts of worthlessness. I can tell he's probably really discouraged, especially after not being accepted on the football team, right? So he may have thoughts like, I just want to feel better about myself, and I want to get over this depression, or he might say, I want to make more friends, or I want to be able to get back on the team, like that might be his goal. But it's important to tie that into the needs there, and of course, suicidality is a big risk, so a need to remain safe is important. But also overcoming that depression. So we would kind of work on that goal. We would come up with objectives. We would come up with strategies to help meet that goal. And so I would then introduce them to the curriculum, which was what I'm going to show you all today with the Steady Teen Workbook, which is the recommended curriculum for adolescents with depression. So we can use other approaches, but we're required to start off with this curriculum with adolescents that have depression. And then from there, of course, we always begin with a session agenda, what it is that the client wants to talk about, what it is that I might want to bring to the table in session and talk about, and then, of course, orienting them to treatment. I'll ask them, like, have you ever been in counseling before? What's that like? And many times clients will say that, yeah, I've been, I hate it, I didn't want to go, and so I'll want to know why, like what was helpful about it, what was unhelpful about it, and then I might ask them too, like, do they remember some of the specific approaches that they learned in counseling or techniques that they learned? I'll introduce them to cognitive behavioral therapy. I'll help them understand like what my role is as a counselor and what I might expect from them. Of course, you also got to talk about confidentiality, limits of confidentiality. That's really important too. And then once the session agenda is established, and then I might begin talking about what are the problems that bring them in, what it is that they might want to talk about, and then we'll start cognitive behavioral therapy. I might have worksheets, I might have a curriculum for them, like a packet ready for them to start using. And I encourage them to take responsibility in their treatment. I kind of want them to become their own therapist, because you want them to kind of work on, overcoming the problems that they have on their own. And the big emphasis in cognitive behavioral therapy is helping them understand the relationship between their thoughts, their feelings, and their actions, right? And so sometimes we'll experience unpleasant emotions because of the thoughts we might have about ourselves. Like Andrew, he's thinking that I'm worthless, I'm useless, I'm no good. And there might be some specific thoughts too. Dad didn't show up to his games, and for a while he might feel like maybe nobody cares enough about me to be there for me. And then I was kicked off the team, so why even bother anymore, So all those thoughts might be behind those unpleasant emotions and lead to the depressive feelings. And then you also look at the actions that he takes. He's might be isolating himself, he's withdrawing, wanting to be alone. So you take all that into consideration, and then you want to help him also change the activities, the actions that he's taking. And the premise of CBT is we can change the way we feel by changing what we do, and we can change the way we feel by changing how we think. And so it's very skilled. You got to be very careful, but you got to, again, build that rapport. No one's going to want to talk to you. No one's going to want to do these techniques with you and strategies if they don't like you. So you got to really build that rapport. It's really important. It's like the foundation of everything. And make sure it's collaborative. Don't just try to, be too direct. Sometimes that's good though, because many times clients don't want to be honest with themselves, right? And so many times we have to, but I'll get into that when we talk about the curriculum, but I hope that covered some things.
Yeah. And Jessica, from your perspective, from the case manager's role, how would you approach this case, and what would be some of the things that you would be working with Andrew?
Well, specifically, like I said, so he has suicidal thoughts, and he's been to the hospital before, or was brought to the ER, so I'm assuming maybe there has been some hospitalizations prior, or there might be, and so he's probably at the highest level of care, like I said, and so that would mean that he does have a counselor, and we're very collaborative with like our team that we have there. So like I said, we have psychiatrists and we also have counselors. So specifically for Andrew, he'd probably have a team of a psychiatrist and a counselor, and then me as the case manager. And as far as services, he'd have a lot to help him. So one of the things that we would probably start off is with a treatment plan. And so like Jimmy said, we'll have the client and the legal guardian come in, we'll start up the treatment plan, we'll work with them to create the goals, the needs based off of the Kansas assessment that we did with them in intake. And then once we have those treatment goals, then they would start off with the counselor, and then we would start to see them in the school as a case manager. So counselors go to the schools, or the kids can come in too and meet with them, and then the case managers also go to the schools, go to the homes, or they can come in also and do the skills in our office. And then the skills curriculum is a little bit kind of like counseling, but it's basically teaching them any type of like social skills, learning about coping skills, specific to like expressing their needs, understanding how they feel, things like that. And that's basically what we would do with him.
So the four of you were working as a team. What would be some of the communication that would be helpful kind of in between the four of you as you're working with Andrew that maybe you would need from some of the other providers, and that you would want to provide to the other providers?
Well, Jessica and I communicate all the time. Case managers and counselors work very closely with one another. So like some of the things might be like, what's it like at home? What's the family environment like? If the case manager goes out and does an assessment, then they might bring some information back like about the home environment. Case managers are really good at updating information about like the school that the client might go to. So a client might change schools suddenly, so those basic things are really helpful. They might help us know like when their next scheduled doctor's appointment is going to be. They might help us know too if there's a change in their medication. And there's a medication component in the CBT curriculum, so it's important for counselors to be aware of that too. And then, I might share with the case manager some updates to just content in our counseling sessions, because we all have consent to talk with one another as a treatment team. So I might share too, things like, client is having trouble making and keeping friends. Well, that seems to also be a skill that the case manager can now use from the skills training curriculum to help them learn ways to make and keep friends. So there might be like a discussion and an interaction about that related to the treatment goals and specific services that they can provide to the client that I might catch on that they might need. And then vice versa, like the case manager might tell me about how the client has been experiencing more depressive symptoms. They recently lost a loved one, right? And so that might be another area that I might explore with them to help them process and find some healing through that. That's how it might be with us. And then with psychologists, we might of course get psychological evaluations from their assessments. And so there are recommendations that are often made which are very helpful, and it kind of helps support our treatment. And if a kid, let's say, is having trouble at school and they're given an evaluation, then we can also see like some reasons behind maybe their problems with like academic achievement. We might see some problems with some of their motivation, and it might help us get a better understanding that not only could it be like mental health issues, but it could just be like learning difficulties that they're having. That's why they might not be succeeding or understanding the concepts that maybe we're trying to teach them in skills training or in counseling. You know, maybe developmentally, the approach we're taking might be a little bit harder for them to grasp, you know, so we try to tailor our treatment to their developmental level, so we take that into consideration too.
Dr. Mohan, any thoughts about that would look like as far as communication or?
Yeah, you know, I think with kids, it's just very, very different. I think that they're, because of their developmental stage, I think it's sometimes very difficult to get them to understand or to break through some of that because they have so much pressure from the outside that is getting through to them. I think one of the good points is that it's real important, and then when they're in that crisis state and they come to the ER, it's also to do kind of with the mother a needs assessment and look at the environment, that if you did send that child back to that environment, what does that environment look like? If that environment does not look good, then you're defeating the purpose, and you may be sending him to the end. So I think that's real important to really get an assessment of that, of the environment, where the child lives, what type of environment. Does the mother work 20 hours a day, 7 days a week, and is never home, so he spends so much time alone and is isolated? That's not a good environment to send him back to if he's having these feelings. And I think that being able to recognize that and open up a little bit. And like I said earlier, I usually am much more open personally to adolescents than I would be to an adult, because I want them to know that we build that bond together, that I've experienced some of the feelings that he may have experienced in life, and to let him know that it's okay, and to let him know that it's okay to reach out, and it's okay to have feelings, but we need to address them, and we need to get him or her help to take care of it so it doesn't escalate into something worse. And I think that that's a real big component of that, and trying to break through some of those, because I just can't stress enough the influences that our adolescents are getting from social media and from peers is really causing awful outcomes with children, as we see in the news all the time. And there are, I think when they're in crisis, you have to be astute of certain cues that when they're in that environment, certain cues that they may say, certain things that they may just allude to just a little bit. So you have to be open and listen. And sometimes I'll sit and in the ER, it is busy. But with these type of patients, I shut the door and I'll sit there very open, and I'll sit there in silence with them as long as I can, to try to let them understand that I'm there, that I'm not just checking a box. You come in with a sore throat, it's very different. But when these type patients come in, it's very important to really open up, and because you could miss that certain thing and you could lose them. And that is a huge piece to me. And I think the decision to admit an adolescent has to be made very gingerly, because they're very different than your adult clients and patients. And I think that if you don't really dig into what is truly going on, then the outcome could be much worse, because I think that they're much more vulnerable than an adult patient.
I think we're about at
Just
10
one,
minutes.
like the communication,
Yeah.
you know, so you work together, so no problem.
Yeah.
But you know, there are all this barrier to communication, has to do with confidentiality.
Yeah.
Like the medical professions, they talk to each other about their patient without any consent. But if I talk to any of you, the parent has to sign consent. So you have to. That's going to take extra time. And lots of the ethics complaints against licenses are about breach of confidentiality. So it's a big part. then at the same time, leaving phone messages, waiting for people to call back, that's kind of like racks up time too. So, so how to handle that? What's the best way? Like if you have people you need to communicate, have an hour where they can call you back when you don't have patients, for example. So that's one, like, some people have electronic medical records, and then it's more easy to sign out who sees who, kind of thing. Or if I'm, like with this kid, maybe he has a learning disability, maybe he has gotten evaluated before to get those assessments. And then for me to know, lots of kids, they have just general low cognitive abilities, which nobody really evaluates, but that's gonna just make learning in general hard for them. Also learn how to remember the football plays, for example. Or maybe it is a TBI, maybe there's a deterioration, before he didn't have he had high scores and now they're going lower, so. But so that communicating and figuring out how to work with others, with a patient like this, if they get more complex, that's kind of additional time outside of the time you'll be paid for, kind of thing. So how to manage that is important.
I want to make sure we have some time for questions. So I think, how much time? About 10 minutes or so. Okay. Does anyone have any questions for our panel? Beth?
So Dr. Reinhardt, you said active to certain cues. Can you give some examples of some things that really trigger that type of astute to certain cues? You used that phrase.
Well,
so some specific cues.
Well, sometimes I will have especially adolescents that have said to me, well, my mom doesn't care, so going back with her, it will just make it worse. Well, why is that? Why do you say that? Is it because you just don't get along, or is it because there's something going on there, maybe an abuse thing, or there may be something going on that you really need to dig into and say, oh, well, why do you say that? And get them to expound on it. Also, talk if they say something about, one recently made a comment about increased crime in the neighborhood and worried about that, and so the stress of that environment. Or if they say, well, the kids at school just bully me. Well, what does that mean, bully you? How are they bullying you? So you can pass it along and maybe share that with the mother when Andrew may not be telling his mother those things that are sharing. Also letting them certain cues about, again, like I brought up about sexuality or about drugs, that they may say, I might do some drugs. The mom may not know that, and that may be causing him. So there's just those certain cues and words sometimes that they'll say that you really have to be astute, because if you miss that, it could have a bad outcome.
And also the difference between non-suicidal self-harm versus suicidal ideation. So there's some kids think about harming themselves lots of the time, but they don't really want to end their life. So that's kind of, we didn't talk about that, but that's another factor in terms of figuring out.
Any other questions? Yes.
Good morning. We're substance abuse providers, and I think we often struggle with staying in our lane, not going beyond our scope of practice. And most of our clients deal with depression. So it's hard, and that depression leads to drug use. So it's hard to kind of treat the substance abuse when you have this depression without, going beyond our scope of practice. So like, should we refer out? Like, could we refer clients to you? And then at what point, like, what do you think depression is? Like, just, we deal with triggers. So if we handle all those triggers, is that dealing with the depression and they're okay? Like you said, you often wonder about the people, like how they do after they leave you. So sometimes I wonder, after
yeah, I refer, even if the patient goes home, I always make sure that they have some sort of follow-up, even just for an intake. I don't care, but it makes me feel better, and it's not about me, but it makes me feel better because I will tell you, patients that have suicidal thoughts or self-harm thoughts are some of the ones that really keep me awake at night after I've seen them, and especially adolescents because they're such at high risk. But I always refer, no matter what, to them because they're the smart people for the long haul. I'm just trying to get them through this kind of acute thought processing phase, right?
Well, we would send kids, but I don't deal with substance abuse, so then I send them somewhere else. But as a substance abuse counselor, you don't just see them. You can see them for depression and substance abuse.
That's what I'm saying, we have to stay within our scope of practice. So really, we're seeing them for substance abuse, but we deal with triggers. And one of their triggers to use is that I'm depressed, I don't like the way I feel, so I use.
Yeah, but can you treat the depression if they still are abusing? And you have to refer them out if they stop using?
Actually, we can't treat depression.
Okay.
You know, that's the scary thing. We can't treat depression. We have to stick with substance abuse. We just will deal with the issues that are your triggers to use.
Okay.
So, like you said, we expand on those feelings. Why do you feel like your mom doesn't love you?
Mhm.
You know, and so we can talk that through. Maybe even have a session with the mother so they can have an open discussion about it. You know, stuff like that. But we can't go in too deep because we have to stay within our scope of practice. But it's hard.
Yeah, they're gonna go back to it unless they get that other treatment.
Right.
And I think it works the other way around too. Like we have a lot of kids who do use because of the depression, and so then we'll refer them to go and get substance abuse treatment because we have, as case managers and counselors, we have specific curriculum that we can use that we have like gone to training for to use with adolescents who do use drugs and alcohol, but it's not the extensive kind of treatment that you guys probably provide. So we refer to you and then vice versa. And then it's always smart to refer because then even if they come in, lots of times we have kids who have been in like juvenile detention and their probation officer will be like, oh, well they kind of told us that they were having these issues, so you know what, you just need to go and talk to, you know, MHID, and they'll do a screening and they'll determine if they feel like you need to continue with services, or at least you know that if you need it, you can come back.
I think it's important too, is that it's such a collaborative effort. Every patient is such a, because you know, not one patient has one issue.
Right.
They have multiple issues. So, right, if they're just looking at the depression but not addressing the drug issue, well, it's not gonna help. And on the flip side as well, and then they end up back with me. You know, so I think that's real important, that all the issues, because again, I don't in the ER, they may have some suicidal thought, but they also have diabetes, and they also have hypertension, and they feel like, I'm on 30 medicines a day, I am not doing this anymore. So you gotta treat the medical to get to the depression, but you gotta treat the depression to help with the medical. So you get all of these layers and factors that are so important, that it's a collaborative, and no one should make a decision about a patient in a box.
Yes.
I just had one question. You mentioned that y'all, a lot of times you'll check the physical side for things that could cause depression and stuff. And I was just wondering how often they actually will usually check it, because I know a lot of times, like with schools, they'll say like the kid's acting out, just they need to go see a psychiatrist. So then the parents bring them straight to the psychiatrist, who's going to see mental health, and they're not going to look at things like maybe he's not getting sleep from sinus issues, which could be causing anger outbursts and stuff. So I was wondering, do y'all usually check things like blood work for thyroid conditions and stuff like that when someone would come in for suicide?
Well, in the ER, we are required to check them every time they come in, because we don't know if there's a substance issue, or it's, you know, their metabolic is out of whack, their sugar's 700, or their sodium's out of whack, or whatever. Or if they've just recently suffered a concussion on the football field. Well, is that causing the issue? So we have to check all of those things every time they come to the ER. I think the problem is, and that's a good point that you're making, is that when in the primary care setting, a lot of times some of those things aren't checked. They go, oh, you're just depressed. I'm going to refer you to Dr. Smith over here, and Dr. Smith will take care of all of that. But they don't look at everything that could cause that disease, the disease process that may be causing depression. But it's not really depression. It's something physiological going on that they just think, oh, you feel like hurting yourself. Well, here, let me refer you to crisis counseling or whatever.
I think everybody has their way what they usually do, so a psychiatrist does this, depression treatment follows this model, right? So then you do your thing, but it could be A, B, C, and D too, right? So if nobody's done that, then you send it back to the PCP and say, well, can you check this? Because we don't know if he has this and this and this. So, but then you kind of have to step back and think outside of your usual.
Oftentimes our psychiatrists will make recommendations for the clients, for the family to go and take the client to their primary care physician, or they'll request lab work. So that's helpful information, and then following up with the primary care physician, they can check other things like their thyroid or check other physiological health issues. But yeah, it can be compounding factors, and you can have somatization occur, which means that from psychological issues, you might have physical health symptoms now occur because of psychological causes, and vice versa. So it's important that we all stay in communication. Many times though, families can be discouraged, like, well, you're sending me over here and I'm still not getting answers, and now I gotta go to this doctor, and then I gotta go over here. They may have trouble with transportation. They may have trouble just having access to these resources, so we need to always take that into account as well. And thank God our case managers are really helpful. They'll pick them up, they'll take them to their appointments many times, like they'll go above and beyond what they have to do.
Well, I'll have patients that come into the ER that their primary cares have sent them over because they're suicidal, and I'll do lab work on them, and their thyroid's out of whack. And I'm like, well, that's why she's feeling crazy. Her thyroid's out of whack. She's in thyroid storm. We give her some beta blockers, and she feels like running a marathon. She feels so good. But those are some of the things that I think that we're just too quick and not looking at the big picture and working as a team. I had a few psychiatrists that I've worked with in the past that would, first thing that they would do once they got the referral is order a battery of lab tests on the patient because they didn't want to send them back to their primary care and they get lost in the shuffle. So I think that's something, I mean, and because it's all a team effort to try to get the patients fixed.
All right, we have time for one last question. Any other questions before we go? Okay.
And sometimes I think, like, if some of these resources was inside the school instead of outside the school, like, it would prevent a lot of this, because I think these kids' sadness turns into depression because they think that I'm the only one that's going through this. I'm the only one that didn't make it on the football team. I'm the only one with a sucky parent. Most teenagers think their parents suck. So they really need to feel like they're not alone. The counselors in the schools now is basically to help with these tests and all this and not deal with the personal problems. Like, I don't know, that probably didn't have anything to do with it, but don't you feel like that too?
But there was some legislation to change that, to mandate that there's a certain percentage of counselor time in the schools
To do just that.
to do mental health services. I don't know if they're planning to hire more people or just mandate what they're supposed to do. I don't know.
Yeah, because you have one counselor in a high school with 1,000 students.
Yes.
So that's, and we know some of the literature says that group therapy is not beneficial, especially for certain age groups. So I think that I think it's a huge problem in the schools, and the kids end up lashing out and acting out.
My husband is a teacher right there, and he said that, raise your hand.
How come you're not sitting back there? What's going on? Y'all need a therapist? We got a therapist right here.
Until the kids sit in the front all the time, so I have to sit But it's like you said, it's one counselor for so many kids, and then on top of that, the counselor is basically the one that does the paperwork for the classes and the one that sets up tests. So, like right now in my school, there's an issue because there are kids needing to see counselor, and it's testing time, and no counselors are available, actual counselors, because they're set up to be actual counselors, but that's not their jobs when administration gives them the things to do, and that's the worst of it.
And if they get reprimanded, it's because they didn't do the paperwork. It's not
Yes.
because they didn't see this kid.
Yes, it has nothing to do with that.
And tell them what the little boy just told, the student just told you the
Oh,
other day.
well, I mean, I have good stories. I have stories every day, but a kid comes in my class and asks, do I ever get sad? And it's, it happens all the time, basically, because they don't get to talk to people like that normally. And I probably talk too much in class, but they think they can ask me that, and I'll tell them. But that's the thing, and it is no big deal to go ahead and talk to them about it, but if I'm not there, who does? And that's the issue.
Well, I think too with primary care quickly is that a lot of primary care providers are uncomfortable with psych mental health issues, so they don't want to open that can of worms. So if they don't open Pandora's box, they don't have to walk it. So they don't want to ask those questions. When I did my doctoral studies, I did mine on ER-related alcohol issues. So they came to the ER related to some sort of an alcohol incident. So looking at and talking to most of them, their primary care had never asked them about alcohol, drugs, depression, suicide thought, anything. They just didn't open that. They were there to get your blood pressure checked, do your annual exam or whatever, and that was it. Okay, got another patient in 15 minutes. And it's not their fault as much because they have to move patients because the insurance conglomerates make them see so many patients. But I have found that a lot of times when they go to the ER, I ask them, well, have you talked to your primary care about it? No, and they don't even ask. So.
All right, we're out of time for today, but thank you so much for